Should we start?
Yeah, I just had a lights going off. It'll take a second to come back. But you can hear me, right?
Yeah.
Okay. Yeah, we can start.
So, we'll wait for the lights to come?
No, that's fine.
Okay. So we'll start. Is it okay?
Yes.
Right. Good evening, everybody. Welcome to this evening episode of Pursue, and this is Pursue 8H Nephropathology, and we are streaming live from AIIMS New Delhi via Kolkata. We have a very interesting topic and two very, very interesting people to present as well as to moderate the topic. The topic of the day is Nephropathology to Nephrogenetics, interesting cases from my practice. I would just like to introduce the moderator. The moderator is Dr. Shubhradeep Mitra, who's an MD from PGI Chandigarh, a DM, and a PDCC in renal pathology from PGI. Presently is an assistant professor at AIIMS Bhubaneswar, and he is also a life member of the Indian Society of Renal and Transplant Pathology. And who better than him to moderate the session? I would request Dr. Mitra to take over and introduce the speaker. Dr. Mitra, please take over and introduce the speaker, and let's start from there.
Thank you, sir, for the kind introduction. I hope I am audible to every one of you.
You're very clear.
Yeah, thank you, sir. So let me introduce Dr. Geetika Singh, who is also a senior from PGI. She is currently working as a professor in the Department of Pathology in the prestigious AIIMS New Delhi. After doing her MBBS from PGIMS Rohtak, Haryana, she joined PGI near Chandigarh and then went over to AIIMS New Delhi. She had national and international honors and awards, numerous publications, and majority of the publications, when I was going through the list of publications of Dr. Geetika, they were published in journals of impact factor more than 4, 8, 3, something of that sort, so which is kind of wonderful. She had a lot of projects in her kitty, and obviously she is a life member of so many important societies, like she is member of Renal Pathology Working Group, International Society of Nephrology, EM Working Group, Band Group in Transplant Pathology. She is also on the editorial board of Pathology. We are extremely lucky to have her amongst us, so I should not waste too much time and hear it from her, all the cases that she contributed to us. Thank you.
Thanks so much, Soro, for that introduction. I hope I'm audible as well. I'd like to thank Dr. Nadeem for this wonderful endeavor, and it's creating an amazing archive, I think, of pathology for everybody in the country, so and around the world. So thank you, and I'm very honored to be able to present here. So I'm just going to present my screen now. And I hope you can see my first slide.
Absolutely fine, yeah. Very clearly audible as well, no issues.
Oh, perfect. Thank you so much. Okay, so I'm glad you found it interesting. We're going to kind of take a step forward from nephropathology to nephrogenetics, and it's really kind of my journey over the last 8 to 10 years and some of the interesting cases that I've handpicked to talk to you about today. This is a quote that I want to start out with. It's by Eckhart Tolle, who is actually a German philosopher. So being at ease with not knowing is crucial for answers to come to you. And I feel in today's era, sometimes, as a pathologist, we should be able to say that this is as far as we can go on the biopsy, and then after that we need more. And sometimes what you need is genetics. And why is it important? Why is it important for you to be able to get that patient a genetic evaluation? Is because, let's say there is a genetic basis to that medical kidney disease. And I'm going to stick to medical kidney disease. I'm not talking about surgical conditions here. There are massive implications. Implications include the choice of therapy. How long do you want to immunosuppress these patients? Maybe it doesn't make sense to continue immunosuppression. Maybe they need to get transplanted early, which is better for them. Who should their donor be? Do we need to check the donor for the same genetic issue? What are the chances of post-transplant recurrence? If it's a genetic issue, maybe there is a very low chance of recurrence, which is a good thing. And prenatal genetic counseling. And like a genetic basis even to cancers, when we talk about familial cancer syndromes, there are certain red flags, and those red flags pretty much remain similar in medical kidney disease. And they include a positive family history, early onset, very early onset of disease, and then some syndromic association. So along with kidney disease, if you have things happening in other organs. So these are the red flags that we all talk about, which we must keep in mind when we are evaluating kidney biopsies. But what we must also keep in mind is that there may be none, and you really need to keep an eye out and kind of tailor your thresholds, considering that you might not have it. So let's start with our first case. This is a 3-year-old male. He presented with steroid-resistant nephrotic syndrome, initial resistance. And he also had some renal dysfunction. So just to give a little background, every child who comes with the classical features of nephrotic syndrome, they're going to empirically receive steroids. That's usually 6 to 8 weeks of steroids, and at our center they do 4 weeks of daily followed by maybe 4 weeks of alternate day steroids. And that empirical steroid therapy may send some patients into remission, which means that they're steroid sensitive, or they may have no response to steroids. So that's what happened in this child. He had an initial resistance, so he never responded to empirical steroids. And that is the usual trigger for a renal biopsy in children. So we're never really going to get the biopsies from a steroid completely sensitive patient. He also had some renal dysfunction. So let's look at the biopsy. I will change my pointer here. Right. So when we look at this core here, it is a core of cortex, but it's so difficult to make out, right? Because you can't really see nice open glomeruli. There's something very funny happening with the glomeruli here. There are 2 over here. No, there's a 3rd one here maybe. And what we can also see is that the tubulointerstitium is also in bad shape. So we're going to assess the kidney biopsy, like Subro taught you, and the initial lectures in this series, where how do we really look at it? We're going to look at all the 4 compartments. So let's look at what's happening in the tubulointerstitium. You have dilated tubules with large casts. They are very flattened, so there's definite acute tubular injury. You can also see shedding of tubules. There's some oxalate crystals there. So you have these paralyzed, acutely damaged tubules, and there might be a little bit of chronicity here as well. So we've got extensive tubular interstitial damage, and we've got some funny looking glomeruli. When we go into higher power, we see what we call a knotted look, maybe yarn balls. There is some hypercellularity there within these pink areas, and then there's a lot of hypercellularity happening around it as well. Then we move on to our standard special stains. So I'm showing you the PAS, and what we see on the PAS is again that this mesangium appears very knotted, sclerotic, partly cellular. You can barely see it here, and then you also have this real component of a very cellular extra capillary sort of proliferation. There's even some stranding there. So anybody who sees medical renal biopsies, we know what the conversation is going to be on this one, but this is something else. So let's see. Let's look at the silver now. This is the Jones silver methenamine. Again, look at the mesangium. It's very sclerotic. It's very sclerotic. And then you have a lot of stuff happening outside of it, right? So crescent, this is not. I'm going to put that out there immediately. This is not a crescent. Why do I think it's not a crescent? I can't see any fibrin. I can't see any inflammation. I can't see any Bowman's capsule disruption. Okay, so now we're left with, well, could this be a collapse? And we'll talk about that. So what I'm trying to bring your attention to really is the state of the mesangium. Let's look at it on the Mason's trichrome. Mason's trichrome here, basically you don't even have the tuft. You've only got that extra capillary proliferation, and then maybe a little bit of the tuft is there. So very funny looking glomeruli. So, what's the diagnosis in this 3-year-old child? Morphologically, this is diffuse mesangial sclerosis. So, you had no open glomeruli, you had a diffuse kidney involvement on this biopsy with the mesangial sclerosis, and what we had in the overlying outside that mesangium was really podocyte proliferation. So, there was a podocytic severe hyperplasia. So we go back and we say, well, is there any family history? Are there any syndromic features? And we know what should commonly come with the DMS. So we're checking, is there any gonadal dysgenesis? And we find that there is none. So what we do is we advise genetic testing, and a clinical exome sequencing was sent by the pediatric nephrology team, and we get a mutation. So this is a likely pathogenic variant. This is how the ACMG classifies variants. This was considered likely pathogenic. It is known to cause FSGS, but look at where the mutation is in. It is in TRPC6. So this was one of those googly cases where we were very sure on morphology at what we were looking at, but the mutation didn't really come out as a common sort of mutation. It is a mutation which is described in FSGS, but it tends to happen in familial cases of adult FSGS. And this case was sent out to many nephropathologists around the world. And this is maybe the second case of a TRPC6 related diffuse mesangial sclerosis. And you can see that the inheritance pattern is autosomal dominant. But we have relatively straightforward cases on record, cases where you really strongly suspect it even before you put the slide under the microscope. So I'm going to show you some images from such cases. This was a 1-year-old male with full-blown Dennis-Drash syndrome with kidney surrounding a Wilms tumor. And this is what the kidney looked like. You can see again that very knotted look of the mesangium here. But in this case, there was really no extra capillary proliferation. So you can get this very variable sort of podocytic hyperplasia. This patient didn't have so much. You see a lot of chronic damage in the background, and this patient did have a heterozygous variation in the WT1 gene proven on NGS with a Sanger validation. So this was a classical case of Dennis-Drash. Another case from our records was a 2-year-old female. She presented with steroid-resistant nephrotic syndrome, but she also had a red flag. So the red flag here was there was a family history of sibling death with infantile, which means even earlier onset nephrotic syndrome. So when you look at this biopsy, this image is what most of the glomeruli looked like, and this is kind of reminiscent to our first case, which I had shown you. You're seeing the same mesangial hypercellularity, you're seeing the same knotted look to the mesangium, you don't have any open capillary loops, and then you have a lot of this podocytic hyperplasia with some stranding there as well, right? However, on this biopsy, there was also one glomerulus which looked absolutely fine. It was only one, but it was one glom which looked completely normal. And there were 1 or 2 glomeruli which had only segmental mesangial involvement. So we had a very strong suspicion. We knew that most of the glomeruli are looking like this, so we still called it diffuse mesangial sclerosis. This diagnosis, because all podocytopathies are going to show you foot process effacement and evidence of podocytic damage, and it may not really help you clinch the diagnosis. It will confirm the podocytopathy, of course, but it may not help you differentiate the different types. What's the usual age group affected? You may even have a DMS presenting as a congenital nephrotic syndrome, which is defined as NS presenting either even in utero at birth or up to 3 months of age, or within the first year of life, which is infantile nephrotic syndrome. And it usually progresses to end-stage renal disease by 4 years of age. So these patients really have no kidney prognosis. And it depends on when you're biopsying. So you may get a 3-year-old. So if you get like a under 1-year-old and you get a DMS, those are easy because, relatively easy because you're expecting, you may expect something like that. But don't forget that you may get a 4-year-old. And there are actually cases on record where a 6-year-old has also been diagnosed as diffuse mesangial sclerosis. So you must keep all those things in mind. And the 3 most commonly described mutations are WT1, PLCE1, and LAMP2. And these mutations may be associated with syndromic or non-syndromic features. And the common syndromes that we recognize with WT1 are the Dennis-Trash and the Frazier syndrome, both of which have gonadal dysgenesis. And the Dennis-Trash syndrome is, of course, associated with Wilms tumor in nearly 100% of patients. And LAMP2 is associated with Pearson syndrome, where patients present with eye symptoms like microchoria and diffuse mesangial sclerosis on the biopsy. The spectrum is also ever expanding. Genetic diagnosis is now much easier, and it is in now the reach of many centers. If not in their centers, there are places that you can refer to. And we might find an ever expanding spectrum which may overlap with other podocytopathies. I also want to put in 2 slides about genetic basis of other podocytopathies, non-DMS. But before that, Subhru, is there anything that...
Nothing, madam. Just Dr. Nadeem has posted Dr. Venkat Iyer's comment that it's a very interesting case of Dennis-Trash syndrome. So that's a wonderful comment, I think.
Yeah. Oh, Dr. Venkat would remember this case, maybe. So he's the pediatric tumor person. So we definitely discussed the case with him for the Wilms tumor part. Thank you, sir. Okay. So I just want to kind of, complete when we are supposed to think about sending a patient for genetic evaluation. So the moment you get a diffuse mesangial sclerosis or you're thinking on those lines, you definitely want to talk to your nephrologist and say, look, I think this patient needs genetics. But there are other scenarios in a non-DMS podocytopathy situation. So what does the data say? So first of all, any evidence of steroid sensitivity, like I told you how these children, I'm talking about children right now. So if we think of any situation where there has been demonstrated steroid sensitivity, so the SSNS, you'll never get the biopsy, it'll never reach you. The steroid-dependent nephrotic syndrome, you might get a pre-CNI biopsy. And then patients who have actually been steroid sensitive and then later become resistant. So those are the SRNS LRs. These patients are unlikely to have a monogenic cause. Okay, so there are studies where people have found the genetic background of steroid sensitive. But when we're talking about a demonstrable monogenic cause, these are not the patients that you would think that you're going to find it. If you have an SRNS initial resistance, so they never responded to steroids. And on top of that, if they tried calcineurin inhibitors, like they tried TAC, and TAC also did not get a response. They did not go into remission. So these are the situations where you may have a genetic cause, and the likelihood is inversely related to age at onset of illness. So absolutely congenital, you have the highest chance of finding something, 69% according to some literature from 2015, 2017. And of course, we're getting better and better at it, right? We're getting better and better at sequencing and making the genetic diagnosis. So these numbers may actually be falsely low. In the infantile, so 3 to 12 months, it's around 50%. And then you see that between 13 to 18 years, it's only 11%. So definitely, if you have a very young patient, she may just have an FSGS. But if you have flags, and if you have SRNS IR not responding at all, maybe you want to talk to the nephrologist. So the flag of family history is so important. See, if there's family history of CKD, that could suggest a genetic cause in 50 to 70% of cases. So I always make it a point to ask family history. And sometimes, it gets missed on the form. We don't get those really perfectly filled forms that we want. So it's always a good idea to go back and check. And what will come wrong in the genetics? I've shown you the important DMS mutations. And for the rest of it, like the FSGSs, nephrin, of course, is the most important slit diaphragm protein. It will present as a congenital nephrotic syndrome if there's a mutation. And then you could get a podocin mutation, a CD2AP, and alpha-actinin 4. So these are kind of the common mutations which could result in a childhood nephrotic syndrome. What about adults? So in adult FSGS, the approach has recently changed. The yields of genetic diagnosis in this were really poor. Until I think a lot of papers came out from Dr. Sanjeev Sethi's group where he said, well, you can't just check everybody. You need to know when to check. So this is a table from his paper where he says, well, if in adulthood you can divide cases into a primary FSGS, which would basically present like a childhood nephrotic, frank nephrotic syndrome, low albumins, anasarca. You'll see an FSGS, you'll see widespread foot process effacement on EM. So that's one group. And then you have the maladaptive FSGS. So he doesn't say secondary, he says maladaptive. And these patients are, for example, the hypertensives or the obese patients, or people who have nephron loss due to surgery and things like that. And they may have lower levels of proteinuria. They will not present with low albumins or anasarca. On light microscopy, you may get some pointers like a perihilar FSGS. You may get other background features suggesting hypertension. EM will have only segmental foot process effacement, right? So here the pathologist role really comes in a little more, where you really want to see your adult FSGS, explore their background, check the EM for foot process effacement. And whatever doesn't fit clearly, that's like the bottom line here, whatever doesn't fit clearly into a primary FSGS or a maladaptive FSGS. Right. So I'm going to go on to my case 2 now. This is a 7-year-old female. So we're going to change track now. We have to think a little differently now. 7-year-old female presented with episodes, gross immature urine, 1.5 months. It's a long duration. She has no edema, no renal dysfunction. She has a 24-hour urine protein of 2 grams and a normal serum albumin. So it's a sub-nephrotic proteinuria. And her serum C3 is normal. So I'm giving you this information because when we think of gross hematuria,
পরে কথা বলছি, একটু পরে কথা বলছি।
at what they thought. So we received the biopsy with a suspicion for IgA nephropathy, but in the corner of the form somewhere, it said, the history of male sibling death. This is an elder brother who diagnosed CKD. He did receive some dialysis. We have no other details. Parents appear to be asymptomatic. This is when we checked, but they were not really evaluated. And an eye ear evaluation of this female was negative. So now we're looking at the core, and you can see it's a very clean looking core, so much cleaner than case number 1. You have back-to-back tubules, and you can see open adult type glomeruli here, and something which looks partly sclerosed there. And let's take a closer look at the glomeruli. There is some mesangial hypercellularity. So we define mesangial hypercellularity as more than 3 cells in a mesangial space, stick to 3 micron sections, PAS stained, and stay away from the hilum. So that fulfills all criteria for a mesangial proliferative. There's an arteriole there which looks fine. And we look around, mesangium seems slightly busy, not so much in this glomerulus or this. We did not find any other endocapillary hypercellularity. There is no apparent Fsgs there either. That's an artery which looks fine, and there is an onset of a little bit of IFTA. You have a few atrophic tubules. Somewhere in the corner of the biopsy, there were interstitial foam cells, right? And on the PAS, they really stand out because the TBMs are nicely, strongly PAS positive, and then you can make out these groups of interstitial foam cells. So my approach to interstitial foam cells is when I see them, I will immediately go back and check for the extent of proteinuria. So if I have frank nephrotic syndrome, 5 grams protein, albumin is 1.2 or 2, then I don't really bother about these because these are just evidence of the nephrotic lipiduric state that is there in the interstitium. But the moment the patient is non-nephrotic, mild proteinuria with normal serum albumin, they take on another significance. Okay, we see the immunofluorescence, it was completely negative, so IgA nephropathy is excluded. And now we go on to the EM. Right, so this is a case from, I think, 2012. So on the electron microscopy, let's see what we can see. The podocytes look upright. You can see that the slit pores look fine. What is wrong is definitely the GBM is just really, really thin. And you can see some lamellations. So this is a normal appearance just to give you a visual, right? So this is a well-formed GBM. That's the densa, lamina rara interna, lamina rara externa, good podocytes, upright. All of them are upright. That's actually the visceral epithelial cell. And then the endothelium. So compared to that, we are in trouble here. And then we look at another area and you see tenting of the external surface of GBM. This is evidence again that this GBM is very weak. It appears rarefied, it appears lamellated, it's quite thick as well. Come here again, same thing happening. There are no electron dense deposits anywhere. And frankly, the podocytes look fine actually, they're not so bad. So the problem really looks like it's in the GBM, and that's another image. And this image just to show you that they were thick and thin. So what was our diagnosis? Our diagnosis was mesangioproliferative pattern of glomerular injury with ultrastructural features of a collagenopathy. So just like podocytopathy is supposed to implicate a disease which is primarily of the podocytes, we can use the term collagenopathy when we are thinking that the problem is primarily in the GBM. So we understand by collagenopathy that we're basically talking about Alport syndrome or thin basement membrane nephropathy. And in 2012, we didn't have access to genetic diagnosis as much as we have now. So this patient didn't get evaluated in terms of genetics. But the story is that the moment we went back with this diagnosis to the nephrologist, they said, but the patient is a female. And Alport's doesn't affect females. They are not symptomatic. So that's why I brought this case out. So we did advise genetic evaluation, but I don't think that happened. So I wanted to bring this out really. So there is a conventional wisdom about Alport syndrome, and this is actually the original paper from Cecil Alport in 1927. So his observations at that time were that male members of the family tend to develop nephritis and deafness, and as a rule do not survive, whereas females may have deafness and hematuria, but they will live till old age, so their kidneys are going to function fine. And this same feeling was kind of reiterated in 1964, where Perkoff et al. Said females usually remain well throughout life, and only rarely have women died of the disease. So in 2012, we still had the same feeling that, well, she's a female, and so that's not a tenable diagnosis. So let's just look at what is Alport syndrome. Alport syndrome is a primary basement membrane disorder. It arises from mutations in genes encoding alpha-3, alpha-4, alpha-5 of the type 4 collagen family. And we know that collagen forms these sort of triple helical structures with the 3 protomers. And what's important to understand is that this combination of alpha-3, alpha-4, and alpha-5 is the major basement membrane type 4 collagen found in GBM, the cochlea, the inner ear, as well as in the eye. So that's why the constellation of features of Alport syndrome, which is the nephritis, the sensorineural hearing loss, and the anterior lenticonus. So that's where it comes from. We also have alpha-5, alpha-6 combination, and that's present in the Bowman's capsule. So that's important if you're staining for collagen. So what's the clinical presentation? Let's look at the nephritis bit. Because you have a GBM defect, hematuria is the most common and earliest manifestation. Gross may be present, so it's one of those differential diagnoses of gross hematuria. Microscopic hematuria will be present in nearly 100% males and even 95% of females. So they will have that. And interestingly, just like an IgA nephropathy, they will present with synpharyngetic exacerbations of hematuria. So we talk about it that, with the upper respiratory tract infection, when you get the cola-colored urine, that synpharyngetic presentation is very IgA. But it's important to remember that approximately 60 to 70% of Alport patients will also have a similar presentation. So these two differentials are the major differentials, and it's it's the immunofluorescence which will immediately exclude the IgA. So that's very important. The proteinuria is usually absent in childhood, but it will eventually develop. So it's a progressive disease. It will keep getting worse and worse, and it will progress with age and can even be in the nephrotic range. So sometimes you can get very heavy proteinurias in 30% of patients of Alport. So if somebody appears to be heavily proteinuric also, again, don't exclude Alport. If you have access to collagen immunofluorescence staining, it's useful, but it has some caveats. It is not as sensitive, but this upper panel is an example of what a normal collagen immunofluorescence would look like. You can see a call for alpha-3 and a call for alpha-5. And this is from a patient of Alport syndrome, and you can see complete loss of alpha-3 as well as alpha-5. And the call for alpha-1 works as a technical control. So we still do it for our patients on fresh OCT tissue. But I think that we've kind of gone beyond that now to genetic diagnosis. Now, what about the eye and the ear? I think this is also very important. The SNHL, the sensorineural hearing loss, is never present at birth. It's also going to be progressive. It usually becomes apparent at late childhood or early adolescence. And however, some families have found to be having a severe nephropathy without hearing loss. So it's not always present. Anterior lenticonus is a pathognomonic feature. We all learn about this. It's also something that worsens with increasing age, and it only occurs in 15 to 20% of Alport syndrome patients. So again, if you have it, it's great, it helps, but if you don't have it, you can't exclude. What's really happening really depends on the mode of inheritance, right? So 85% of Alport syndrome patients are X-linked. They will have a mutation in call for alpha-5, which is present on the X chromosome. And those males who have it are going to have all abnormal call for A5, so they will be affected. And the females who have it have one normal and one abnormal X. And they are considered to be, or were considered to be, carrier females with variable outcome. The second most common mode of inheritance is autosomal recessive, which is present in 15% of patients, and that is present in col4 alpha 3 or col4 alpha 4. And these are usually heterozygous, compound heterozygous in trans mutations. And you will not see the difference between males and females. So that's a classic autosomal recessive inheritance pattern. Dominant is very, very rare, and I think it's actually been excluded in the latest terminology. So who is our patient? We think that our patient who has a history of male sib death, we don't have evaluation of the parents, but we think that this is our patient. She is technically an Alport, in inverted commas, carrier, but you've seen the state of her GBM. So what happens in X-linked Alport females, the so-called carriers? We understand that the genotype-phenotype correlation is not good. They have a variable clinical presentation, and that is, of course, because of the effect of lionization. So if the X inactivation is skewed towards suppressing the bad X, the one which has the mutant, then you're going to have a good phenotype, and vice versa. So it really depends on which X chromosome is suppressed in the lionization. Extreme skewing towards the mutant allele will result in a severe phenotype, and this is what we think was happening in our carrier female. How do we know that they are lionized towards the bad X? We will know just from clinical and pathological presentation. If they are presenting with gross hematuria, not only microscopic, if they have SNHL, if they have significant proteinuria, and if they have EM changes like we've seen in our patient. So we definitely know that this carrier female, unfortunately, is clinically significantly affected. And if you look at this Kaplan-Meier from a paper which came out in 2003, you see that the probability of end-stage renal disease in males who have X-linked Alport is, of course, much higher, 100% by 80 years of age. But look at it at females. You know, it is significant, 40% in the older age group. And if you look at between 40s, so in your 40s, so around 20% of females will reach end-stage kidney disease. So that's a significant. And considering we just, March 8th just went by in Women's Day. So what about X-linked Alport syndrome females as kidney donors? I really like this line out of this relatively older paper. That's when I was actually reviewing it. You know, you get that case and then you start reviewing. And there was a paper on women and Alport syndrome. And it said mothers feel guilty of transmitting the mutant allele to their sons. So I'm assuming that when they undergo counseling, they're told that this is what has happened. And they feel a moral responsibility to donate their kidneys. But what the science says, it says that Alport heterozygotes, which is what these mothers are, they should only be kidney donors of last resort. And if you can really not find anybody else. If this mother has proteinuria or hearing loss, they should be excluded from consideration as kidney donors because they themselves do not have completely normal kidneys. And if they donate one of their kidneys, their own renal function is definitely going to be significantly hampered. Only heterozygous females with isolated microscopic hematuria, normal kidney function, normal blood pressure, normal hearing may be considered after careful counseling about risks. So this is so important. So unless you make the diagnosis, if this patient reaches ESKD and the mother becomes the natural donor, so you're not giving them the best kidney, and then the one who's donating is also losing a kidney and will be in trouble later. Right. So, bro, take a break here.
Yes, ma'am. Okay. So, as you have mentioned, we have seen two very interesting cohorts which we do not easily, and those cases what you showed were extensively worked out. So, because you are working for some time now on pediatric nephrotic syndrome, so I want to ask you a few very basic questions. The first thing is, the first case which you showed, madam, was a case which you diagnosed as angina sclerosis. My question would be, how can we distinguish logically between diffuse mesangial sclerosis, and a collapsing glomerulopathy. As you have mentioned rightly, that previously the age was kind of a guide to us, because diffuse mesangial sclerosis used to happen at an age below 1 year or 2 years, and but as you were saying that it is gradually the spectrum is increasing, and this case I was astonished to see that TRPC6 was the culprit. So I really don't know whether when to label it now as collapsing and when to label it as diffuse mesangial sclerosis. What is your take on that? That's my number one question. The second question is, a good number of DMS cases occur because of either Dennis rash or Frazier, which are WT1 mutant. So WT1 being a marker of podocyte also, have you ever tried doing WT1 IHC on these cases, and if you have, then what were your results? So this I am interested to know.
Okay. Okay. Thanks, Subhru, for those questions, especially the first one. You know, we went through a lot of kind of heartburn on the first case, and it went to a lot of people. So the bottom line was that don't look at the podocytic, you must look at podocytes and how the hyperplasia is going. But the clincher on that first case was the look of the mesangium. So the knotting of the mesangium, it's not an imploded tuft, it's a sclerotic looking tuft is what gives you the diagnosis. So I don't know if you've seen Dr. Helen Liapis's paper. She has described spectrum on DMS.
Yes.
So we sent the case to her as well. And the opinion from her is also that these patients do get misdiagnosed as collapsing. And we went back to her with the TRPC6 information also, and she was like not surprised. She said, you know, we've seen overlaps in everything. So I think that's a little eye-opening for all of us. You know, we like categorizing. Like I see a lot of issues in categorizing. आपने पहले MCD बोला, अब आप FSGS बोल रहे हो. आपने पहले FSGS बोला, अब आप MCD बोल रहे हो. I'm sure you've gone through this kind of discussion with your nephrologist. And you know, frankly, it doesn't matter. Okay, whatever you're calling MCD, there might be an FSGS somewhere, you know, and or there could be a progressive podocyte loss. At the end of the day, it's understanding that this is a podocytopathy and that we have to look at its steroid responsiveness and then kind of move on. You know, like pathology gives you the first step, but then you need to move on. You can't stop there and the discussion can't stop there. So I don't know if I've answered your question, but maybe when we all look at our cases now, that we shouldn't be missing the DMSs. And I'd say if you are finding very funny looking glomeruli and all of them look like that, then be careful and kind of don't get too swayed by the podocytic hyperplasia, because it can be.
Can I make a point here, Geetika?
Hi, ma'am.
Yes, ma'am. Hi, good evening. Yeah, from both of us.
I have one case of DMS in my book also. It is TMC, and I was also wondering if it is a DMS or if it is a collapsing glomerulopathy. So I was, after going through some reading, I did a Ki67, and that is what helps. They say that if the Ki67 is negative, and of course other features are there, then it is a DMS. And in collapsing glomerulopathy, the Ki67 is very high.
Is very high. Absolutely. And even morphologically, you might see mitosis. We've seen it. You see mitosis, you see podocyte resorption, droplets, they look very activated. Thank you, ma'am. I don't think we did it on this case. बहुत tiny tissue था, outside review biopsy था. But that's a good point. I'll try it on my next case. And Subhru, the second point that you had about the WT1. So we've not tried it on our DMSs considering mutation WT1 में होता है. But you know, I just want to get across that WT1 will be lost in nearly all podocytopathies. It just becomes an abnormal podocyte. So it won't help you in kind of confirming the diagnosis. So, but we don't do it. No,
I did WT1 as well, and it is very strongly positive. The crowning came out very well. In fact,
Did it? Okay.
When you go through that chapter,
I'll do that.
So there was the crowning went very well in that. So the WT1 was very strongly positive, but the Ki was totally negative.
Was negative. So I don't have WT1 with me. Oh no, but we have it in routine. Yeah, maybe I'll try. Maybe I'll try that as well.
You can do that.
Yeah. Thank you, ma'am.
Okay.
Okay. So
ma'am, please proceed.
I
Yeah.
will go on. So I'm kind of on my same case. Okay, so case 3 now. 23-year-old male. He has a history of frothy urine for 5 to 6 years, and he has bilateral sensorineural hearing loss. He has a family history of CKD. He has sensorineural hearing loss in the mother. 24-hour urine protein 1.5 grams, serum creatinine 1.7, and he's got microscopic hematuria of 18 to 20 RBC. So, bro, can I get you in? What do you think the patient has?
So frothy urine. Yeah. Okay.
Sensorineural hearing loss hai. Mother also has.
So obviously you are hinting towards an Alport.
Right.
And the male patient
male.
also. Yeah.
Yeah. So we're thinking the patient should have X-linked Alport syndrome,
Yeah.
right? Okay. And then we look at the biopsy, and the biopsy has these glomeruli, which I thought, little stiff, but we'll have a look at a higher power. And you have groups of interstitial foam cells, so you've got another positive feature. Sometimes I do see this in our male patients with full-blown Alports. You will see an appearance of slight thickening of the capillary walls, and you'll find nothing on silver. So again, it's a good thing to note. Go on to the silver. You're not seeing any textural changes on the capillary walls, and they look a little stiff. Okay, so now we do the EM. We're pretty sure we're definitely going to see everything. Lamellation, tenting of external surface, but this is the electron microscopy on this patient. You can see a very well-formed lamina densa. You can see that the external surface is quite smooth. You really don't have lamellations and rarefactions. And you can see that the thickness is quite okay. You have 280 nanometers, 290 nanometers. So thin GBM is under 250 nanometers, which was there in parts. So it was not there. So this was one glom. We come to the second glom, maybe slightly thinner. But still, you don't have tenting, rarefaction, lamellation is not present. And these are the measurements on the thin. I actually have 260 here, but then I have a little bit of 190 and I have a little bit of 170. What I want to go back to is, let's look at the podocytes as well. It's always a good idea to look at both of them. You look at the podocytes, well, there's some flattening. There's a lot of microvillus transformation. So we do have a lot of effacement also. So not as clean as the first case in terms of podocytes. Okay, so let's just quickly look at what should the GBM look like. The normal adult thickness of GBM in the Indian context, there's only one paper, that too from PGI, from Dr. Charan Singh. So he's a PhD, worked in EM, mere time pe bhi the. And he's the only one even now. So that's the only paper you can quote. The main GBM thickness was 321 nanometer with a standard deviation of 28 nanometer. And Western texts are pretty similar. It's around 350 nanometers. So maybe we're slightly thinner, but not really significantly. And what's important to remember is in younger patients, it's quite significantly thinner. At 1 year of age, this is from another reference, it was around 197. So it can be less than even 200 nanometers in very young patients. But we expect texturally and in terms of layers, it should all be normal. So the problem in this patient was, well, I'm having trouble on the EM. So do I want to suggest that this patient has long thin segments, and should I call him TBMN, which is thin basement membrane nephropathy? Of course, the moment you hear the clinical history, the answer is a big no. You do not want to utter the word TBMN. TBMN is also known as benign familial hematuria. It's non-progressive kidney disease. Patients are fine. They don't need anything. How do you diagnose TBMN overall? You need to demonstrate a thin GBM with a width of less than 250 nanometers. And it's not just a little bit of thinning. You need long, thin segments. And that's approximately at least 50% of the GBM. And you're not supposed to find that sort of textural change. So you're not supposed to find all that lamellation that you find in Alport syndrome. So in the correct clinical context, long, thin segments on that, you may think of giving a diagnosis of TBMN. If you're doing collagen stains, you can check that the collagen staining that you're doing is preserved. What do we think on this patient? I'm not going to utter TBMN, so we give a diagnosis, non-proliferative glomerular histology with ultrastructural features favoring a collagenopathy. There was a long note with this diagnosis because there was a lot of podocyte injury as well. We were not sure why the podocyte injury was appearing so much, and in a patient who's so clinically strongly, the phenotype is so Alport, we're not finding those changes on the EM. Of course, we do have a reason there. So this patient did undergo genetic testing, and there was an absolutely pathogenic, not even likely pathogenic, good pathogenic variant, which proved that this patient had an X-linked Alport syndrome. So it was in the call for alpha 5, right? But what I want to bring your attention to is that it's a very small, it's an SNP, that's just a missense mutation. So what are we really seeing in this? We're seeing the genotype-phenotype correlation, right? In males, there's actually a very good genotype-phenotype correlation. If mutations are small, including missense mutations or a small splice site mutation or a small deletion, everything is going to occur slowly later. So the GBM changes are going to progress with age, and renal failure and deafness may occur after 30 years of age, and this would be kind of the adult form. So we had a 23-year-old with a missense mutation, and my bet would be that if we biopsied him 2 years later, 4 years later, we're going to see progressive worsening of the GBM. So I think that's a very important point. You as a pathologist cannot exclude that diagnosis. If you do not see a full-fledged Alports, you need to keep the whole picture in mind. On the other hand, when patients have major rearrangements, we're talking about frame shifts or large deletions, they may present at a much younger age, which is called the juvenile form. So unlike in females, where there's not such a good genotype-phenotype correlation, so it doesn't matter. What matters in the female is the site of lionization, but in males there is a good genotype-phenotype correlation. The other important point to note is that Alport syndrome has no hotspots, so you can't ask for anything less than sequencing. So you could do a targeted sequencing where you're sequencing all of alpha 3, alpha 4, alpha 5, or it depends on where you're doing it and how you're doing it. You could even do a full clinical exome. Okay, I'm going to move on to case 4. Now this is a 12-year-old 12-year-old male. He has a history of anasarca for 2 months. He has microscopic hematuria. He has 2+ protein with a creatinine which is deranged at 1.54. All his serologies are negative. And the only red flag we have, it's definitely there's a bilateral sensory neural hearing loss. So again, there's a constellation of findings. I have a 12-year-old, it's a male. I have microscopic hematuria and I have bilateral sensory neural hearing loss. So I'm not going to show you the histology because they're pretty much the same. This patient also had some mesangial proliferation and his IF was negative. So this is the electron microscopy now. You see the mesangial proliferation here. You can see that there are too many cells embedded in this matrix. So it's definitely mesangial-proliferative. And I find that mesangial-proliferative can cause a lot of confusion sometimes. But, it's good to remember that a lot of collagenopathies and even, initial resistant podocytopathies can show a lot of mesangial hypercellularity. And we've all done those mistakes of thinking, nahi, ye IgA hi hona chahiye. So we should keep in mind that mesangial proliferation is a very common pattern of glomerular injury. So this patient did have mesangial proliferation, and then when we look at the low power, we see that the podocytes seem mostly upright, a little bit of effacement, but the GBMs look very, very thin. GBMs look really thin. Come here again, podocytes look okay. This is 100 nanometer. 100 nanometer, long thin segments, and texturally doesn't look so bad. So our diagnosis was ditto to the last case. We said it's a mesangial-proliferative pattern of glomerular injury with ultrastructural features of a collagenopathy, and we advised the same. We said do a genetic evaluation for call for alpha 3, alpha 4, alpha 5. And they were all negative. So there is no mutation in any of call for, A3, A4, A5, nothing. And it turns out the patient has a pathogenic variant in M/H9. I couldn't get hold of the full report, but my pediatric nephrologist tell me, oh, you thought it was Alports, it's not Alports. They're very happy. because it's actually something else. It's an MYH9. So were we completely wrong? That's what I look like when we got that information. No, we were not too far off, because this is actually one of the most common mimics of Alport syndrome. MYH9 is an autosomal dominant disorder. It is basically a non-muscle myosin heavy chain. And hearing impairment is a very important feature. You may even have some eye symptoms like a cataract, and you may also have platelet abnormalities. So what I've now realized is that, and the EM changes, like I showed you, it looked completely like a collagenopathy. There were long, thin segments there. Long, thin segments, male with sensorineural hearing loss. So it can be a complete Alport mimic. And if you are advising genetic evaluation, it's not a bad idea, if they're doing a clinical exome sequencing, to specify, do the call for, but also do the MYH9. And that's what we are really doing nowadays, that we make sure that we cover this. Because ek hi bar mein aap, at that same cost, figure out both things. So that was a relatively interesting case of ours. So points to remember about collagenopathies. All Alport syndrome patients don't present with classical hearing loss or eye changes. Requires a high index of suspicion. Always keep an eye out for any family history or presence of hematuria. Glomerular morphological changes are completely non-specific, and you can get very confused because there might be mesangial hypercellularity, there might be appearance of capillary wall thickening, and the EM will help, but you've seen the riders. And immunofluorescence for collagen, if you're doing it, it may help as well. Don't consider the female carriers to be benign, but they are women at risk for developing disease, and they should be evaluated as well. And thin basement membrane nephropathy should never be diagnosed without understanding clinical context. And if you can get genetic analysis, of course. So TBMs basically behave like heterozygous ARASs. So they'll have only one mutation instead of being compound heterozygous for the alpha 3, alpha 4. So they're actually kind of a much milder form of Alport. And keep in mind Alport mimics, and if you do have control of what is getting sequenced, then getting the MYH9 in there is also a good idea. Right, my last case. Should I go ahead, Subha?
Perfect.
Okay, so this is a 6-year-old male. He's born to non-consanguineous parents, and he presented with nephrotic syndrome. Now, there were a lot of other relatively, I thought, vague symptoms. There were persistent GI symptoms of vomiting, postprandial diarrhea from 12 months of age. So he's had it for around 5 years. And also some forms of some neutropenia, so some issues there from 24 months of age. His endoscopy was done for these GI symptoms, they were normal. There was a sweat chloride test which was abnormal, on which the patient was diagnosed as exocrine pancreatic insufficiency. He progressed to pancytopenia. However, bone marrow was normal and he had a normal karyotype. And urine PC ratio is 3.2. So this is a classic nephrotic. So he's hypoalbuminemic, he's hypercholesterolemic, he had normal renal function. So he was a frank nephrotic with normal renal function, and then these symptoms in the background. All serologies were negative. Family history was also negative. And on the form, what clinical diagnosis we received was suspected Schwann-Diamond syndrome, which, like everybody else, we Googled because we had no idea what it was. We get a lot of syndromes in our diagnosis sometimes from pediatric nephrology. And it's supposed to be something, patients have bone marrow failure and exocrine pancreatic insufficiency. So I guess that was a very good fit for them clinically, except the kidney. So the kidney was not a fit in that syndrome. So he underwent a biopsy. And when we looked at the biopsy, this is what we saw. I have 2 glomeruli relatively high power for you. And the mesangium again looks maybe slightly busy. There was no FSGS, there's no endocapillary hypercellularity. So that's that look. In the tubular interstitium, they were mostly back to back. But there was this small sort of histiocytic collection which was surrounded by lymphocytes, and some suspicion that what could this be? Could this be a small granuloma or something like that? But if you still pay attention to the glomeruli, you'll see it. And then in high power, it becomes absolutely clear that we have a diffuse podocytic vacuolization. You can see that there's this fine vacuolization involving all the podocytes. So we have a diagnosis. IF was negative, and we go ahead with EM, and you can see it. It's full of myelin figures or zebra bodies within the podocytes. That's a higher power. So just to orient you, that's the GBM. This is the podocytic cytoplasm, and you've got these beautiful myelin figures there. Right. So we had a diagnosis. We had non-proliferative glomerular morphology with histologic and ultrastructural features of a renal lipidosis. So we can't really call it, but it is very suspicious for a Fabry nephropathy. This patient then a pediatric nephrologist, I don't know, I think they believed us in the first go. Once we showed them the EM, they believed us. But they went ahead, we have to complete the diagnosis, so we get enzyme levels checked, the leukocyte alpha galactosidase activity was low, and a clinical exome sequencing was ordered, and it was proven that there was an X-linked, likely pathogenic mutation in the GLA gene. So this was a proven case of Fabry nephropathy. But this was a very unusual presentation, a very young patient, which is not the usual age. So what is Fabry nephropathy? It is an X-linked lysosomal storage disorder due to deficiency of alpha galactosidase A, which results in accumulation of the GL3, which is the globotriacyl ceramide. So this GL3 accumulation in the form of intralysosomal inclusions will happen, and it will also happen in the podocytes. So for us, it is that extreme podocytic vacuolization. So you have to stay away from focal podocytic vacuolization, which is very common, especially around an Fsgs, and you'll see it as you go into high powers. That's not enough. You need to see a really diffuse podocytic vacuolization. The more classical features which this patient didn't have are the neuropathies, the angiokeratomas, and the Fabry cataract. The usual age at presentation is around 30 years. So this was a very young patient. And the renal involvement is due to toxicity of the accumulated GL3. 11 to 23% patients will present with nephrotic range proteinuria. Why we couldn't call it immediately is because there are other renal lipidosis which can be mimics like Niemann-Pick disease, Hurler disease, etc. And I've recently seen somebody post a case of a Niemann-Pick with glomerular involvement. And the other important differential diagnosis is iatrogenic lysosomal inhibitors, which I think would be an important differential in older patients, especially if they've been on a lot of hydroxychloroquine, which people are on nowadays, and even amiodarone. So that's it. Thank you for your kind attention. I'd like to take this opportunity to acknowledge people I'm working with and people I've worked with who've inspired me. Professor Dinda in the department, Adarsh, who's working with me, also from PGI, and Dr. Tambra, Dr. Joshi, the whole ISRTP group actually. It's been a pleasure learning from them over the years. Thank you so much.
Thank you, madam, for your wonderful presentation. The cases were really well documented. We come to see from pathology all the parameters, you went ahead with the genetics, so it's a complete roundabout. I just have one question before I take on to the other comments which you have received. The question may appear a little cheeky, and that's for the last case, especially for the Fabry disease. I just wanted to know, did you look the podocytic vacuolation in the first go or in retrospect?
Okay, so I'll tell you what it was. It came in, I think it came in Dr. Adarsh's, so we divided in 2 weeks. It came in Adarsh's reporting, and we were looking at it, and I think he got swayed by the granuloma. But you know, I don't feel nice things, but I picked it up in the first go. I saw it on the H&E, but the vacuolization it's crazy when you just need to go into that high power and observe. And after that, you know, we've all been, Adarsh and I, when we look at our cases, we go into that high power. I go into oil immersion a lot as well. I don't know.
Okay.
Yeah, especially for membranous nephropathies and all. So really observe those podocytes, and yeah, it was one of those lucky pickups, I think. And you kind of wait for these diagnoses. You hear about them in conferences and things like that, and you're waiting for your first case. So that was my first case. Yeah.
Right. That's really wonderful to know, because when you showed the case on the first go, I could not pick it up, frankly. So when you said, it was a cheeky question that came in my mind. I think Dr. Nandita is trying to say something. Yeah,
So,
madam.
about the neutropenia in this patient and the exocrine pancreatic insufficiency, so how do you relate to those things?
So actually, ma'am, it is described. So GI symptoms are described. I'm not so sure about the pancreatic, but the malabsorption, I don't know if they were not so confident on the pancreatic insufficiency in retrospect. Once we gave them the diagnosis, then they went back and said, well, there was malabsorption, which is is described in Fabry's.
Yeah, because Forshman-Diamond syndrome is pancreatic. What happens is that you lose the exocrine pancreas there. There's
Right.
infiltration, and only the islets are left around, and there's a bone marrow failure, neutropenia.
Yeah.
I've reported I did a CPC on a Forshman-Diamond syndrome.
Okay.
Published.
I'd never heard of it. So we were, sitting at the microscope and googling, like ये होता क्या है पता भी नहीं क्या. But
Yeah, lovely cases. Thank you so much, Geetika. Thank you.
thanks, ma'am. Thank you.
Okay, madam.
And Geetika, I just want to tell you one more thing. I had a case of Niemann-Pick syndrome, and in those, I just have my book out even here on the table.
Yeah.
And there were these cells within the glomerule, in the mesangium.
Yeah.
Niemann-Pick cells in the mesangium.
Right.
And this patient was also having some glomerular issues, beginning to have the glomerular issues, but she died.
Okay.
Yeah.
Okay. I really want to see that. I want to see all of those cases actually now. I'll pick it up. And
That's in the book. Actually, you can go through those.
I'll do that.
have a look.
EM tha, ma'am, uska. Were there those?
Yeah. I did the EM also. It's right here.
Lovely. I'm buying that.
Thank you so much. Thank you.
Thank you, ma'am. Thanks so much, ma'am.
Okay, this is really wonderful for Nandita ma'am to share her experience as well. Yeah. So, Dr. Achan has said good evening, and Dr. Mahesha. Dr. Mahesha, are you here? He has already written that excellent lecture to listen as always. Beautiful collection of illustrative cases highlighting morphologic details, when to suspect and push for genetic evaluation. All cases were challenging, educative, and followed with relevant literature for the viewers. This is a wonderful comment.
Oh my God.
Yeah, Mahesha sir, being himself a renowned, really brilliant nepropathologist, this is a wonderful comment. And
thank you so much. So the first case, Subro, I have to tell you, I sent it to everybody.
Okay.
Dr. Mahesha gets most of my difficult cases to have a look at also.
This is same for me, madam. This is same for me. I also take help of him.
Yeah. He's a great help. आजकल तो WhatsApp पे भी हो जाता है. Thank you, Dr. Mahesha.
Excellent talk, Geetika. अच्छा था. Very nice to know about this detailed approach. Especially, I like the approach what you follow, clinical as well as histology. थोड़ा बहुत हमें clue मिल जाता है. Not to really.
Yeah. I think in nephropathology, especially, you just cannot get away from understanding the clinical context, and you have to be calling up the nephrologist. You have to actively call them and ask, ये तो नहीं है, वो तो नहीं है, and we are constantly kind of in touch with them to find out more the moment we have any suspicion. Yeah, but they're very good, I have to thank my nephrologists. They are so good. They will take a call anytime, and they're very open to discussion. So thanks, Dr. Mahesha.
Yeah.
I love to see his cases. Yeah, his staining is so good. Steal some of his technicians, basically.
It's all because of the technicians. nothing, nothing from my side. It's all the techs.
Yeah.
So Dr. Varun Bajaj has posted that excellent cases, madam. Thanks. No more comments.
Okay. Thanks so much, Subro.
Yes, ma'am. Thank you. This was a wonderful learning for me also. I will see my cases in different light nowadays. Okay. Thank you. Thank you, ma'am.
Thanks so
Good
much.
evening and good night,
Good
everyone.
night.
Over to Nadeem, sir.
Yeah.
Thank you. It was Alice in Wonderland for me. That's all what I can say. Yeah, true, absolutely. Wonderfully done and so crisp and so clear. The concepts are so nice and good. So nice to have you, Dr. Geetika, here on this platform.
Thank you so much for having me. It's been an honor,
Yeah.
Dr. Nadeem.
It's an honor for us as well for you to be here. And as you rightly said in the beginning, we are creating a nice repository for all these things for everybody to learn and go back and see again and again. And as you would be understanding in the national and international context, everybody is not free at a given point of time.
Right.
And you are not
True.
free every time.
Yeah.
So when you are there and you are talking on a topic like that, people would love to go back and look at it. And
Yeah.
the feedbacks which we get, we would like to share is that people are very happy to go back to that YouTube and the PDFs. Now we have the PDF and the Google Drive. All of them we have uploaded. So we share the Google Drive link so everybody can see every time they want to. And these videos are of significant help. And especially if coming from people who are sitting in the center of all activity, because people in the periphery, you may not have any idea. People sitting in the peripheries just don't get access to all these things.
True.
So for them, it's actually a Alice in Wonderland effect. But having all of you here on this platform, coming and teaching, taking out time, and now that I won't say it's a resurgence of COVID. I think we are almost through with that. Now with the routine activity back, it's a commendable job to take out time from your busy schedule and come and talk here, in the evenings. Thank you so much. Thank you, Shubhra. Thank you, Mahesha. Thank you, Dr. Nandita, and so many other people on the YouTube. Thank you for joining in.
Thank you,
think
Thank you.
we'll
sir.
have you again and again. Thank you. Bye-bye. Take care. God bless all of you. Bye-bye. Good night.
Thank you. Good night, sir.
Bye, Shubhra. Thank you. Bye.
Thank you, sir. Bye.